Everyone, this is so exciting to greet and meet. Today we are the EIC for Children Innovation and Improvement Center, welcoming Ann Dietrich, and the topic of the webinar, Emergency Room and Pediatric Mental Health Needs, Opportunities and Challenges, Every Step of the Way with Ann. Just a few seconds, I want to introduce Ann. She's awesome. So a little bit about Ann. She has joined Prima Health as Division Chief for Pediatric Emergency Medicine in summer of 2021. Her passion includes teaching, scholarship activities, mentorship. She holds an appointment as Professor of Emergency Medicine at the University of South Carolina School of Medicine, Grenville. After completing her residency in pediatric and fellowship in pediatric emergency medicine at Nationwide Children's Hospital in Columbus, Ohio, and committed herself to education and excellence at all levels of clinical training, she has worked with medical students, residents, fellows, and junior attendings to elevate each learner to the best he or she can be. Please join us in welcoming Ann. Next slide.
Thank you, Anna. So I'll go ahead and get started. Welcome, everybody. Please feel free to stop me any point along the way. Today, what we're going to be doing is talking about the journey of a child with behavioral mental health issues as they go through the emergency department. And we're going to discuss challenges, which I think all of you are aware. There's a lot of challenges in triage, screening, ongoing care. And then we have challenges with dispoing these children to get them the help that they need. Next slide. So first I wanted to start, frequently we talk about kind of mental health crisis, and really behavioral health related emergencies this is the definition that's been given. And there's kind of there's multiple categories, but we've got suicide risk, harm to others, especially like a homicide, ideation, or risk of interpersonal violence, or severe lack of judgment that may unintentionally endanger either the individual or others. Next slide. So I kind of divide this into two areas. And we have recently done an AHRQ grant that has looked at mental health. And I apologize, my dog is adorable, but she just does not know when to keep her little snout closed. So about 13% of children age 8 to 15 years have a diagnosable psychiatric order, but that's not the only children we're dealing with in the emergency department. We kind of have had and it was really brought out by COVID, although if you look at the national numbers, they were starting to climb before COVID. We get the mental issues with the suicidal ideation, suicide attempts, those kids that are really severely depressed, that were concerned about their own personal safety. But the other thing that's happened in the emergency department is we're now dealing with a lot of behavioral issues, and these can be just as challenging, if not more challenging, because of our lack of resources, both in the community, in the hospital, and then outside the hospital. So we've got autistic children who will develop some aggressive behavior. We've got kids with cognitive disorders that develop aggressive behavior. We have some of our congenital children that will have self-injuring behavior, either as part of their syndromes or as a reaction to whatever the genetic syndrome that they have. Next slide. So all of these kids start out in our community, and I'm kind of going to walk you through what we experience and then kind of talk about some of the challenges, but maybe there are opportunities for us to enhance our community resources, to improve things so that we can give these kids better care or better overall care. So we've got first the pre-hospital situation, and any of you that have dealt with the emergency department know that we get EMS and police will get called. I mean, I must have had 5 kids last week alone that were called from children acting out where they punched a hole in the wall. The police get called, the kid's 9 or 10 years old. What do they do with them? And so frequently they'll put them in an EMS vehicle and send them to the emergency department for a mental health assessment. How do we tell, the mental health issues from the behavior issues, and what is the best way to handle those things? Should those kids be taken care of in a crisis center? Should they be kept in the community? Should we have a mental health response team? that goes to these communities and evaluates, or goes to these children's home and evaluates them in the home setting without transporting them into the hospital setting. Other options, could we have some walk-in centers where parents who have these children with the special needs could go, like a mental health crisis center, where they could get help, where they could get some medical screening, whether they could get an evaluation. And I think all of us who work in this area know how challenging it is. I mean, I said to the police officer, because this kid, you won't believe what this kid did, was a foster kid. She managed, she's 9 years old. She locked her foster parents out of the car, took the keys, started the car. And then the police came and blocked her in so that she couldn't drive the car. And they brought her in for a mental health evaluation to the emergency department. And I respected the police officer. He's like, she's 9. But at the same time, should we come up with some other resources for these kids? Next slide. And I'm going to have a hard time, I'll be honest with you, reading the chat. So if you have any questions, just pause me and ask them. That'll probably be easier for me.
And we do have a question in the chat. It's to the earlier slide we had. And the question was, thank you for the data. We were talking about data regarding
mental health and psychiatric
yes.
decisions.
Do you know how the 13% compares to national data for 8 to 15-year-old?
No, I do not. And honestly, every place I looked, I got a little bit different numbers depending on what they specifically were looking at and what categories they included for their mental health issues, which I think is one of the things we've been struggling with. So the national guidelines, the SAMHSA, SAMHSA, someone to talk to, crisis call centers. I've had several kids tell me that these are really, really valuable. They offer some de-escalation, connections to ongoing care when needed. Sometimes families don't even know where to start. Like, they know they've got a problem, but who do they call first? Where do they call? And I think every one of us has been in the difficult position of them saying, I've made multiple calls and I haven't been able to get anybody that could help me. And that's why I put them in the car and brought them here, is because I just couldn't find anything. And I was worried that things were going to get worse before they got better. Someone to respond. I really like this idea. I'm not sure how I don't have the wisdom to know how to make it work, but mobile response teams. Could we have them go to the kids' homes, to the schools? I mean, we frequently will see these crises escalate at schools. I've had a number of kids with that have been in the situation with bullying, and the bullying has gotten so bad that they react, and then they say they want to hurt themselves, and they're at the school, and the school's trying to help the kids and trying to figure out what to do. Could we have some qualified responders, especially within large school districts, that go out there and have resources and provide that family and youth peer support providers, and then trying to keep them and work out the situation in the environment where it occurs, rather than separating them from that environment. A safe place to be, crisis receiving and stabilization services, so that these kids have a place to go, so that they get developmentally appropriate trauma-informed care in crisis care facilities. We had a child that was brought in. I have some of the best nurses in the world. I'll tell you what, they're just incredible. But one of the nurses noticed this, we had 5 security guards there because she was flailing out and hitting people and screaming and really angry and hostile. And the nurse came up and said, hey, let me try and do this. Can you guys separate a little bit? And it turned out this child had been raped. And so the fact of having 5 men surrounding her when she was upset was making the situation so much worse for her. And when it went to just the nurse, and then she de-escalated her and calmed her down, and we got her in a place that looked more like a room, it was just the reaction and the aggressive behavior completely declined by 400%, it felt like to me. Next slide. So I love this Critical Crossroads toolkit. I think it's just incredible. EMSC Innovation Improvement Center has so many resources, and I'm sure all of you have just been, I love them for education. I love them for toolkits. I love them for I need to do a survey. Do they have any samples there? Do they have things that can help me? And I like how they approach the whole issue. So they start with, and we're going to walk through the rest of the emergency department visit the same way they do. So what they do is medical stabilization, which, to be honest, is the one thing you absolutely need an emergency department for. No matter what anybody says, if you've got medical concerns or a child needs to be medically screened, at this point in time in history, the emergency department is probably the best place to start, because we can do that medical screening, medical stabilization. Then do you initiate screening? So do all the kids that come into the emergency department, do you screen them all? Or do you screen ones with certain chief complaints? How do you manage that screening process? Then once you have them in your system, you have to do ongoing assessment. And one of the other things then, once you've done your ongoing assessment, is do they stay or do they go? And how as they come in and you decide they're going to go outpatient, what resources do they need? If they want to go inpatient, is there a bed immediately available? And we're going to talk about some boarding issues, which I am sure a lot of your facilities that you're aware of have been dealing with. I mean, boarding's been a really big problem for us with the mental health issues, especially for our younger kids. Next slide. So let's talk about the beautiful place I call my home, the emergency department. Medical stabilization. I personally love my environment, but as you can tell from the pictures, that might not be the ideal environment for either a child with autism. It's very scary. It's very loud. There's a lot of people moving around. There's a lot of people doing a lot of things that need to be done. They're got lights that are bright. Frequently, we do not have a lot of access to windows, and that's a safety issue for making sure the emergency department stays safe. We've got all different kinds of kids. So you don't just have kids that are 17 and 18. You've got 3-year-olds, 5-year-olds, 7-year-olds, 10-year-olds, 12-year-olds, 16-year-olds, 18-year-olds. And we all know, although sometimes I find it challenging with my adult colleagues to remind them that a 9-year-old is not a 16-year-old, very, very significantly different in terms of their understanding and their approach. And then we have mental health versus some of these behavioral issues. Can we help? I mean, we frequently struggle, and we have psych available with how do we help these kids with behavioral issues? Because really, we don't have the same resources that we do for a child with suicidal ideation or a child with major depressive disorder. Next slide. So what kind of medical stabilization do we have? Well, we have kids walking in, and unfortunately, I think I've seen all of these in the last 6 months. They can be near hanging, an almost near hanging, overdose, ingestion. We see a lot of overdoses and ingestion, and those kids require medical stabilization. How do you do your medical job and at the same time take care of the protection of the child, and also the stabilization of the child from the psychological standpoint? So you've got kind of two issues going on. The sicker they are, to be honest with you, the less the psych issues probably come into play, meaning that if you've got an unresponsive child that you have to intubate, breathe for them, give them fluids and things, you've kind of got them sequestered so that they're not going to be doing anything. Those kids that are still awake and talking, you've got to protect them while you're getting them detoxed and making sure that whatever item they ingested is out of their system. We always hate the discussion of chemical or physical restraints, but I will tell you, we have a beautiful, he's a really sweet child, but when he has like one of his outbursts, he's 240 pounds and he may be 5'11" or 6 foot. All I know is I'm 5'2" and he's a lot bigger than me. And how do we keep them safe and keep my staff safe? How do I keep my nurses safe when these children are having these aggressive outbreaks? And you've got to kind of balance the environment, because you don't want to put your nursing staff at risk while you're trying to get these kids under control, meaning turning the lights down might not be the best thing for my nursing staff while we're trying to de-escalate the child, and also control the agitation. If they're there for a period of time, unfortunately, sometimes you'll go through like these kind of waves where it's like one of the nurses will talk to them, get them all calmed down, get them all set there doing something. And then an hour later, they get hungry or they're tired of doing that. And then all of a sudden we've got some more agitation. And how do we handle that ongoing while they're in the department and make sure that we keep eyes on them and keep them safe and my staff safe while they're in our department? Next slide. This is another resource from EIIC that I just love. It's Care of the Agitated Patient. And the lovely thing about this is that it gives you a single sheet of paper that you can post or you can distribute to your nursing staff, or you can distribute. We have a lot of residents that come through. And so a lot of times I'll give them some resources to look at because as they go out and they're in some of these community areas, they may need something like this. And this is kind of nice because it's geared towards children. It makes sure people assign roles. It also reminds you, sometimes people forget. I remember I had a kid brought in years ago and EMS had left the kid at the scene and the kid was really agitated and just really kind of flailing around. And mom, I don't know how she got the kid in the car because he was like foot taller than her. She got the kid in the car and she brought him in and the kid had a shunt. He had a shunt and his shunt wasn't working. And so, the first thing I said is, do you have any medical problems? And she goes, he's got a shunt in and he's just been getting more headaches and he's been just more agitated. And sure enough, his shunt wasn't working. So we've got to be absolutely sure that we don't miss anything medical. Hypoglycemia, hyperglycemia can make kids more agitated. Then the most important thing I think in the world is de-escalation strategies. Having in your toolkit, in your repertoire, things that you can do to talk down a 10-year-old, talk down a 12-year-old, get them to calm down without having to use medications. Because the problem is with the medications is if you have to use them, they only have limited effect. They have to come off of them. The kids feel funny. So you're back in the same position when you use them. And I will tell you, sometimes you need them. But if you can do it with de-escalation strategy, that's going to be the most helpful. Make sure that the medications are done on weight-based dosing so that they are appropriately dosed for age group and size. Frequently, I admit it, I will look at the mother and say, have they ever done this before? And if she says yes, I'll say, and what did they give him the last time that seemed to work? And a lot of times you'd be amazed. The mother can tell you exactly what medication and how much it took. I mean, I had one mom look at me and she goes, they tried 5 and it didn't work. They had to go up to 10. Thank you very much. That is very, very helpful. And it also tells you that this has been a recurrent problem versus a new problem. Monitoring, and that's something that in the emergency department, we have to be very careful of. We have a behavioral health unit where we can place the kids, but when we've got them on medications, we usually want to keep them in beds where we've got nursing staff close because we want to make sure that they don't have a reaction to the medication, or when the medication wears off, we don't have to do something more. Next slide. If you ever want to open up an open war between emergency medicine, nursing, psych, everybody, just say, what do you think about suicide screening? You will find this is just a really hot topic. And honestly, I'm going to tell you some goods and bads about it. I like the idea of universal screening, and I hate the idea of universal screening. I don't know how many of you have gotten kids from the public schools or from the pediatrician's office who have failed some of these screening tests. And I will have kids come in with their parents and the mom looks at you and goes, they gave her that piece of paper and she got a score of whatever and she failed. And you say to the kid, do you want to hurt yourself? And the kid looks at you and goes, no. Have you ever thought about it? Well, yeah, a year and a half ago. And so you end up having all of these different things brought to life. The good news is you might have someone who is depressed that people didn't realize was depressed. And so then you can do a save where you catch somebody and get them resources before something more dangerous happens. But they're very difficult. And you have to realize that if your hospital or your setting decides to do universal screening, you have to deal with all the yes answers. So you've got to have systems in place then to provide resources and to make sure all these kids that answer yes, that you have things in place to take care of them. I also like the exposure to violence or violence and aggressive behavior. I think those screenings are incredibly important. But again, then when you get the answers, you've got to decide what you're going to do with them and have systems in place for that patient. We have a system where the kids go immediately to rooms if we have rooms available. So our screening, you can screen in two places. You can screen in triage, or you can put them in a room and then screen them. The problem is if you put them in a room and then you do the screening and it fails, you might have to move the room or change the room to make sure the room is safe, depending on what the child's answers are. The hard thing with doing it in triage is, I don't know how your triage systems are. The one here really does quite a good job. They've got like a private little office, but the door's usually open. And so asking kids these kind of questions, I think it's challenging in an open environment where they can see other people and they're worried about other people being able to hear them. So those are just other factors to consider. Next slide. So these are, I picked two triage screening things. This is the Ask Suicide screening questions, and it's 4 questions about risk factors and 3 questions about suicidal ideation. The thing I like about it is that it's free, which we always like free. My institution is always more willing to pay for free than anything else. And they've got a full toolkit that is available online. And so it's really, you kind of got quick access if you want to start something. It's well tested. It really does a nice job of assessing suicide risk factors and suicidal ideation. And there's a couple of studies that have backed it up. It is recommended. It can be used for pediatric patients in the ED for any kind of visit type. And I do think, you know, I struggle with some of the trauma patients, but with some of the things where you're worried that it was intentional, I think this is a good set of questions to ask to help screen some of the patients that might be looking at broken arms and, you know, other traumatic things that you're going to have to take care of. And it's also been validated for use in adolescents in the emergency department. So this one has also been validated in that population. Next one. This is the Columbia Suicide Severity Rating Scale. This is the one I've had the most nightmares with. They use this one in the school, and sometimes I'm not sure that kids know how to answer some of the questions. So we have had a lot of kids transferred for failing this one who, at least when we assessed them, did not, when you personally talked to them, meet criteria or have enough risk factors. But it's supposed to assess the severity of suicidal ideation, and it's a prelude to the more comprehensive CSSRS test. It's validated for use in adolescents. And it's recommended by US FDA, and it's in the NIH-funded Phoenix Toolkit. So it's got some people who like it. I've just had more false positives with this one than I have with the other one, but that might just be the population. And I think sometimes kids, especially in the schools, when they've been bullied and they're in a reactive mood, sometimes we'll answer them differently than when they're out of the school with their parents, sitting in a nice room, you know what I mean, feeling more safe in their situation. Next slide. I found a couple of kind of cool models that I thought I really kind of liked. The empath model is like what I would call, you know how you have like those ideal dream things that you would just always say, oh, if I could only have that. And this is a model where if you look at that picture up there, that's where they go. I would even like to go there. The environment is calm. They have the adjustable lighting. They have patients, they see patients, the staff is stable there. And so they see patients over an extended period of time. And the staff are purely mental health professionals. So they are all geared towards the specialized training. And so they know how to interact and intervene. And there are some places that have used this as a model where they've had a separate build and they screen them in triage and then they move them in the empath model. So they immediately go to where they can get the resources they need. Nice thing is they stay out of the chaotic emergency department environment, so they immediately go someplace where people are geared to what their problems are. And so, I mean, if I could give this to everybody, I probably would. Next slide. There's also another model that I found out of Lancaster General Hospital, and they did this with adult BH patients, but they had a triage nurse, and then if they met certain criteria, they would bring the adult physician, the emergency medicine physician out there, and they would talk to the family or talk to the patient, and they would get a behavioral health consult while they were still in triage. This is another thing I dream of. And then they could take them, and if they identified they had substance abuse issues for one thing, or they had a specific issue, they could triage them to appropriate resources and move them directly to those resources so that they didn't have to go into that chaotic environment and then get re-triaged again and then wait. They could actually, especially during the daylight hours, they had resources that would take the patients directly so that they could shuttle them in between these different areas. So basically, they did the medical screening exam and triage, made sure they identified any BH issues, and then targeted answering their specific needs. Next slide. So we all know Joint Commission has certain rules, and all of our rooms must meet special room constructs. We've got regulatory guidelines, and they're basically geared to make it so that there's nothing in the room to keep the patient safe. So that we can keep them safe. And I had a child 2 weeks ago take and rip her paper pants and shirt, and she made a strap with it and was trying to hang herself in her room with a strap off the paper clothes. So I think it's really important that we recognize there is a risk. And so we want to keep them as safe as possible. The problem is, should we keep them as part of the ED? We currently have one room where we put, when we don't have enough room in our BH unit, we have one room that we've made safe and set up everything so that there's, because even those cords on the ophthalmoscopes, otoscopes, I mean, think about it. You could wrap that around your neck and fall backwards and it's attached to the wall. So we take out otoscopes, we take out ophthalmoscopes, they take out all the equipment. You've got to be careful with the sheets because they can make the sheets into knots. So it's really something to safely consider. If you look at the second bed's wall, you'll see up there that you've got wires that could be going around someone. And so it's really important that we consider those things. The idea of separate beds kind of goes with the empath model of, should we move them to an area that's more ideally designed for calming people down and giving them a chance to de-escalate and making them feel like the environment is a little bit safer versus keeping them next to the trauma room where people are screaming, is the surgeon here? Is this here? Is this here? And, them feeling like it's a much more chaotic environment. I struggle tremendously with age group divisions. I've had kids that have had behavioral mental health issues down to 6 years of age. And I like the idea of a separate unit, but I do not like 6-year-olds with 17-year-olds. I don't think they should be together. And how do I split them? Because if you've got someone who's getting aggressive, they could rile up the rest of the patients that are in that area. And so how do you separate them, get one child de-escalated before you put them in that setting where they're going to be around other patients? Anna, was there a question?
Yes, we had a question in the chat. Is asking, at what age would you start the suicide screening? Currently, we are using CSSR.
I would like to tell you that there is a specific age group. In children that are cognitive normal, I believe that they've started at 8. The problem is I don't know, and I'd have to do research for you, which I would be happy to. I don't know what age group you can start with the autistic children. And some of our kids that are cognitively challenged, I don't know what age group to start with them. And sometimes I will ask the first question, and then I will ask them, are there any words you don't understand? And if there's more than 2 words in the sentence they don't understand, then I just mark it out and go to, you know what I mean? Like, say it's not going to work, because the biggest problem we have is a lot of our kids have some cognitive challenges, and you don't want to have them answering these questions just because they don't understand them. Next slide. And if anybody wanted to put stuff together specifically for the children with autism, that would be awesome, because I find there's a couple of recommended screens that I found that people will recommend using. But again, it depends on whether they've got mild, moderate, are they high functioning? We've all dealt with the differences in the kids, and it's like night and day. I mean, there's kids that you can hold complete conversations with and they can answer. And then you've got the kids that, you know, you're getting the stuffed animal for the 16-year-old and trying to show them on the stuffed animal not to be scared. And so I think there's a wide variation for those. So after we've gone through and we've triaged them and we've got them in a bed, then we've got to do our ongoing assessment. And this is sometimes, I think, one of the most challenging parts, because now you say, okay, this is a mental health issue, this is a behavioral issue. How do we keep them calm while we're waiting for all of our resources? So I am blessed. We have a ped social worker that we can get pretty quick to kind of come in and start to do some of the family assessment. And we also have an emergency psychiatry program, which we are so lucky. They've hired 3 child adolescent psychiatrists. So we have access to them. But believe it or not, they're swamped. So sometimes it takes a little bit of time. Medical assessment, we still keep with the emergency department, and our psychiatrists feel that until we've medically cleared a child, they will not do a psychiatric assessment. And I respect that, because you know what I mean? If a type 1 diabetic has a glucose of 700, I don't know that they'd say the same thing when they're at 700 that they'd say when they were under control. So we have to get that diabetes under control, and then we go back and talk to them, and then we decide what resources they need. Safety assessment, this is a nightmare if any of you have been in there for resources. If we're, you know, for concern, we need a sitter. We need someone with one-on-one eyes on that child, and then we need to manage them if they have any agitation or behavioral escalation, and know what we're going to do for those kids. Next slide. So a lot of times, we will assess them for safety. I've been very, very fortunate. A lot of the families will stay with the kids, but that's, again, something you're going to have to decide in your emergency department, because when they go to our BH, our behavioral health unit, the parents can't go with them. It's a shut off unit with 24-hour videos with all safe rooms. I like my younger kids. In fact, I'll usually request my younger kids stay in the emergency department, just because I found that separating mom and child does not go well for a kid who's in crisis. And so frequently we'll make individual decisions about where we're going to keep them based on what we think is safe. And the other thing that people don't like, but having had one of my pregnant nurses kicked in her abdomen last week, which scared the crap out of me, we've also got to take care of our staff. And you've got to protect them. I mean, and pediatric nurses frequently get pregnant. And so we've got an obligation to make sure that they're safe. And you would be amazed at how hard a 6-year-old can kick. Although any of you who've tried to hold a 6-year-old down probably know how hard they can kick. Getting consults and then getting a disposition. Nationwide Children's had a little thing that was released. This was a year ago, just talking about trying to keep employees from attacks. And that's the hard part when you're trying to be calm and nice and you've got a child who doesn't understand. Sometimes they get aggressive and they do things, and sometimes it's not intentional. I'll be honest with you. Next slide. This is something that I wanted to put in something that kind of talks about where the literature has taken us. So one of the things that sometimes will happen is we'll get all these facilities will say, I can't take that child until we get certain laboratory tests back. Or have you done COVID testing? Because we're not going to take them anywhere unless we've got COVID testing that's negative. So there were at least 2 articles or 2 research papers that have come out showing that if you had a negative history in physical, most of them had negative exams, and the testing was just not going to help you at all. If you've got concerns, if the child's got medical issues like diabetes, clearly you've got to do some screening lab tests. But the majority of kids we're seeing are previously healthy with no medical problems. And so, finding out that they have iron deficiency anemia, and only one had a disposition changing result, and it's the only test I routinely order. I either need to know whether you're pregnant or not, because that makes a huge difference in terms of placement. And sometimes it explains why we're having the behavior we're having, to be honest with you, especially in 13 and 14-year-old girls. Testing on average was $1,200 per patient, could save $90 million if we eliminated it on a national scale. And a lot of it is from the facilities that we try to screen these kids for. And they'll say, no, we're not going to do it without a CBC and a CMP. And I will not talk to the adult geriatric population because they're different, but in our kids, we rarely find anything medical to fix. Next slide. So we've got them, we've done our workup, we've got psych social work to see them. Do they go inpatient or outpatient? That's kind of the big decision we have to make. If they're going outpatient, we've got to put them into a situation where we're giving them the best chance for success. If you look at the national figures, it's kids that threaten or have suicidal ideation. Their highest risk period is the first 30 days after that event. We've got to keep them safe. How do we keep them safe if we're going to send them home? Outpatient resources. Can we link them to primary care? Do they have a primary care doctor who's willing to see them and willing to help the family navigate these mental health issues? Can we get linkages to community mental health services? One of our facilities down here is an intensive outpatient program, and I had a family, they're kind of the dream family, you know what I mean? Like both of them had a lot of depression in their family, understood the whole thing, but they didn't want to do the facility. They wanted to do outpatient. And they were able to, our social workers performed a miracle, able to get them signed up to go the next day. Would that be interested? But then the family felt like they could be more involved, which they felt would be better for their child. If we're going to send them home, I'm going to go through some home resources. And this is the work of EIIC. They have so many excellent resources with discharge packets to make sure that the child is going to be safe. We know that there's a lack of, could you go back? There's a lack of telepsychiatry and e-health. And so those would be another option. Inpatient admission, transfer to another facility. It depends whether you have a psych unit at your facility and what age groups it accepts, and then transfer to another facility. Next slide. Fewer than half the children received a primary care specialty follow-up visit within 7 days after a psychiatric diagnosis. Our study that we're doing with the AHRQ, we surveyed parents, and their number one complaint was that they had tried to find their own resources and could not find anything as an outpatient, and that's why they showed up in the emergency department. And when we try to do this, to say, okay, let me get you in to see somebody, it is so hard. And any of you who have tried to get these appointments for these kids and to get them into people who they can then have as consistent resources during their therapy. And actually, it didn't matter what kind of insurance you had, which I kind of thought was interesting, because you would have thought if you had insurance, it would be better, but it was irrespective of insurance type. Risk of suicide attempt or death is highest within 30 days of discharge from an emergency department or inpatient psych. And that's why this follow-up piece is so critical and so important. And we all know what it is. We don't have enough psychiatrists. We don't have enough behavioral health workforce shortages. I will tell you, I tried to find, we had an autistic child that was placed in foster care and was having a terrible time. I don't know how many hours that social worker spent trying to find an outpatient resource for that family. And it was very, very difficult. And then lack of reimbursement for care coordination and in general for behavioral health. Next slide. Home, make sure with the outpatient resources, we put together one of the projects that one of my psych residents put together as part of the suicide collaboration, which was a wonderful collaborative from EIIC. And it was a packet that had all of the different pieces that you would need to go over with. So this goes through some of the low acuity discharge acts, and can you schedule a PCP? We now have a one-click where we can schedule an outpatient visit. We also found this great group of pediatricians that are just starting a practice, which means they're not full yet, who will see these kids 24 hours later and help them find a pediatrician, help them find community resources. Social work to make sure that we've got everything all set. Nursing to make sure we've got nursing and medications are clear, and then making sure we've got a behavioral health outpatient appointment, behavioral appointments times. Next slide. This is just some of the resources that you can find at different websites, and it's my safety plan. And it's actually interesting, especially for the kids like 9, 10, 11, 12. It really helps them to talk them through some of these things. And it helps them focus, what do I do when I get scared? What do I do when I'm starting to feel like I can't control the situation? What are things that I love? What are things I care about? And so this is a nice little tool to kind of talk the kids through it. We actually do this, especially if the kids have to stay in the department for longer. Next slide. So healthy, this is some safety planning, social supports for the patient, identifying people that you can count on. And it's interesting. This is when you find out sometimes what's interesting. Like, I had a mom that had like 7 kids. And this child was just very depressed, very suicidal. And this child identified grandma as being like the person that she felt would do anything for her. Okay. And, it was interesting because then social worker started talking to mom, and mom's like, let me call grandma. Maybe we can work something out. And then grandma said, well, my name, what I mean? So to build a team of people that are actually going to help this child and be responsible for this child and look out for this child. Also making sure that they have contact information for outpatient. And we're very clear about how to get back into our system if they need to. And then the next slide, my psych resident did an incredible job. The other thing is means restriction. So this is also community resource crisis stabilization services that you have available. Then the next slide. Follow-up phone contact. It was interesting. They talk about if you can get them in with someone that will follow up with them within 72 hours and check on them. This was a high satisfier for families, and it also made them feel like people cared. And if they were having problems with the resources we gave them, it gave them a second chance to ask questions. I mean, you think about how much information we give families, and what do we say they remember? 10 to 20%. So having that phone call is very, very valuable. And then family intervention for suicide prevention, making sure that they have that so that they can call if they end up in a crisis situation. Next one. My psych resident did this packet together for us, means restriction. I'm in South Carolina. So I think there are more houses with guns than without guns. But what they talk about is physically impeding access. And there's actually, Anna, you may know something about it. There was a program somebody was talking about to me where they were going to give out, Anna, it may have been you, give out the lock boxes for the guns.
Yes, we actually did give out lock boxes for the guns, but we actually just in addition to it, in Rainbow Babies and Children's in Cleveland, we put a proposal towards more funds for actually we asked for it all. We're looking to gain more funds for medication lock boxes as well as sharps and gun lock boxes. So more to come, but we're excited for this opportunity hopefully come our way. So staff is happy as well, because this is often noted to be an opportunity, especially for our Medicaid patients who may not be able to afford a lockbox necessarily. So that more to come. Thank you for asking.
No, and I think that it's something we don't think about. But when you talk to the families, I remember I went in to talk to the one dad and I said, hey, there's just a couple more questions before you go, because he was like, we'll get into the doctor tomorrow. Mom's already called and got an appointment. We're going to do this. You can count on us. And I said, do you have any guns in the house? And his eyes just like blew up and he goes, yeah, I hunt. And I said, can I ask a favor? Can you lock up the guns? Can you take all the bullets out and put them in a separate location where you have the only key? And he looked at me and he goes, I'd do anything to protect my son. He goes, I hadn't even thought about that. And I was like, so making it so that it's not easy for a reactive person who's in that situation where they're reacting instead of thinking, to not have easy access to something that could cause a problem. And also the medications is incredibly valuable, because that's the other one that people just don't even think about, will take handfuls of. And the weird one is, Tylenol, everybody thinks is so benign. You can kill yourself faster with a bottle of Tylenol than you can with almost anything else. So, I mean, it may take a little bit longer, but at least your liver's not going to be happy. Next one. Inpatient care. We have had, I know no place in the country has enough inpatient care. If you've got a medical patient that has medical problems, for me, that's the easiest, because then I can get a medical bed, but then I have to have a sitter go with them. But I've still got a medical bed, so I can get them out of the emergency department and upstairs into a medical bed. So like our overdoses, our kids that have done something that they need to be monitored for 12 to 24 hours, those kids will medically admit, but we need a sitter to go with them, which is a huge strain on hospital resources. But then they can also get the psych consult upstairs. Psychiatric inpatient care, it depends on your availability and how busy they are. Sometimes it's relatively straightforward to get some of these kids transferred there. Sometimes it's just a matter of bed space. We have done much better with our psych and our social worker team working together and making sure that they have relationships with all of these facilities so they know what's available and what's not available, and kind of keeping track of that. And also identifying expertise within your state. We have we don't have beds for kids under 9 to 10 years of age, except at Charleston. And so the kids that are like 6, 7, 8 years of age, that's the only place we have. So sometimes that's going to be more challenging to get them there. The other thing to think about, although no one wants to think about it because this was such a disaster, I don't know, 20 years ago, 25 years ago, is the residential care setting. We don't have enough places for kids that require residential care, especially our special needs populations. Some of our autistic kids that are severely affected, some of our kids that have some of our syndromes that have difficulty handling themselves and controlling themselves do require residential care. And I was told by one desperate mom that she had called and they told her it would be 6 to 9 months before they could help her at all. And she did identify some outpatient resources to try and get some help. But she had 5 other kids in the house, and that's very, very challenging for a family to handle. Next slide. This is one of the last areas, borders. These are kids waiting placement. I think it's a very huge challenge for any hospital that's trying to do the right thing. I hate having 6 and 7 and 8-year-olds in rooms with nothing to do. Can we provide counseling and psychiatric evaluation? We don't have enough resources to do all that, although everybody is trying. Social work tries as hard as they can to get resources and placement. Some of the kids actually get worse while they're in those kind of isolated environments and they don't have the opportunity to play. They don't have distraction things. Go to the next slide. And I think that Anna was going to provide you with this resource, New England Behavioral Health Toolkit. Boy, is this thing cool. It is a bundle of tools that is for patient safety and satisfaction for children with behavioral health conditions. It actually is a toolkit with all different kinds of choices. So you can pick what you use or what you don't use. And you can modify their resources. They don't care. So you can look through them and say, hey, this would work in my department. This wouldn't work in my department. And it's just invaluable. Go to the next one. I've got some slides on it because when I found it, I was like, this is just incredible. The one thing, it provides safe activities for distraction. The only problem with this is you need to make sure your staff knows what is safe in which age group, which I have no problems with nursing, but sometimes people forget that 2-year-olds will stick almost anything up their nose or into their ear, and you do not want that to happen while they're waiting in your department, especially siblings with the kids. But they've got different kinds of recommendations. They've got them by age group. They've got different things for them to build, different things for them to look at. Go to the next one. They also have like this coping tool, which I really liked. And it kind of talks about what do you do when you're stressed? What do you do when you're angry? And it helps the kids kind of express their emotions. But the other thing is you can do it with the parent. So the parent can tell you, oh, when I pat his back like this, it helps him calm down. And I think all of us who have kids have probably done this, because you know what calms your kid down and what doesn't. But it's nice, especially with some of the kids that have autism and things, because some kids will be more sensory driven, some kids will be more sound driven. And it's nice to know that those sound blocking headphones are very helpful when it gets close to bedtime. And then they give you some different things to what helps you feel better. And that gives you some ideas of things to do for the child. Next slide. I think the emergency department, we completely lose perception on time schedules. My kids used to hate when I went to work because I work 2 to 11. I get to bed at 1 a.m. You get up at 9 a.m. Every day you're on a different schedule. But we all know that children thrive on set schedules. And this is also from the New England Behavioral Health Toolkit. It's a little daily schedule while they're stuck in your department. Don't forget their breakfast. Let them wash their hands. Set a goal for the day. Check in with your provider. No, you're going to call your mom this time. You know what I mean? If they're in a separate place. And it goes through just a nice schedule for the day. And so that's another resource that's in this toolkit. Next slide. I did it right on time, Anna. Aren't you proud of me?
Very much so. So we'll have time for questions, but we also, in a few minutes, would like for everyone to take an evaluation survey. It's just a 4 questions, simple survey. And with that, looks like it's being administered right now. Please take a look. The first 3 questions must be answered. The 4th one is optional, but please do if you have the information. That will help us plan for future events. And with that, we're going to keep it up for a few more minutes and let you submit. We want to see if there are questions, please add them in the chat. And if there are suggestions, please just unmute yourself and speak up.
And this is my opportunity to say thank you for all you do. This area is so challenging and you do not know how much help is appreciated. And I think the one thing people sometimes forget is that most pediatric people, all we care about is that the kids are okay. Honestly, that's all I care about. So anybody who can help me do things better for them or make it better for them is going to be tremendously appreciated. And even simple things like having, kits for the kids to do while they're in the emergency department, while they're boarding for a short period of time, enhancing those outpatient resources, helping identify these kids before they're in crisis. Several of the parents, when I talk to them, will say, this has been going on for the last month. I tried my pediatrician, I tried the school counselor, and you're like going, I feel like sometimes we let them down because then they come to us when they feel like they just don't have any other choice. And we want to do our best to make sure that they get their resources in a timely manner. Any questions for me, Anna?
I'm looking at the chat. I'm not seeing anything right this moment. I do have one thought here. There's a lot of folks on the call who are representing community resources that might be available. If there's one thing on your wish list that you wish to have from like public health perspective in your state, what would that be and help you handling the kiddos in the ED with these?
it would be
Opportunities.
incredible as some of these kids, and this is just one subgroup, but our foster kids and a lot of our kids with autism are identified, I hope early, you know, so that we can give them as much help as possible. But having community resources when those families hit crisis points, or, you know, for the foster kids that go from place to place, having them hooked in with the community so that they would have somebody that was, I don't want to say an advocate, but maybe an advocate for them. Having those resources available, those screening tools where those kids are identified, and maybe targeted help. I was kind of frustrated. I had a family come in and their 4-year-old had the developmental milestones of a 2-year-old. And I called our behavioral health clinic. Do you know what their waiting period was? 18 months. And I was like, you know, I looked at the family and I was like, I'm going to try and expedite it. I'm going to, you know, try. But I think that so many of the developmental programs that have been started for like our preemies and our high-risk kids are phenomenal. I mean, they've just made a world of difference. I saw a 17-year-old that was an ex-22-week preemie, and who would have thunk? The kid was absolutely fine. So I think that we've developed so many models that I hope we get ones for this too.
Thank you. All right, I'm not seeing any more questions in the chat, so I think we can stop recording at this point. And thanks, Anne, for joining us today, and thank you, the folks on the call. We really appreciate all the questions, and looking forward to help out and work together.